So let's go through this important question, which I've found shows up in a lot of AMC recalls and tests your knowledge of COPD and being able to read an arterial blood gas. So we have a 71-year-old man. He presents to a regional ED. He has shortness of breath, increased drowsiness. He has severe COPD, ischemic heart disease. He has a 50-pack year smoking history. His resp rate is really high. He has an SpO2 of 81%, which is quite low, on 4 litres of nasal prongs. He has a high heart rate, BP is pretty high as well, and he is febrile, and his GCS, it's okay. So he has diffuse wheeze and coarse crackles at the right base. So we'll have a look at his ABG now. So this is important to realise that this is on a fraction of inspired oxygen of 35%. Okay, so remembering that normal fraction of inspired oxygen in room air is 21%. So take this into account when we're reading this. So we can straight away see that this patient is acidotic, they are hypoxic, they have severe hypercapnia, remembering that they're on a relatively high fraction of inspired oxygen, and they have some partial renal compensation here. So what we can see from this question here is that this patient is in a type 2 respiratory failure. Remembering the difference between type 1 and type 2, type 1 we have low oxygen, type 2 we have low oxygen and high carbon dioxide. Okay, type 1 can be usually due to something like pneumonia or pulmonary embolism. Type 2, it's usually that we're not being able to blow off CO2, so it can be COPD, asthma, neuromuscular diseases kind of like myasthenia gravis. So it's important to realize why COPD patients retain CO2. So they can get airflow obstruction, we can get loss of elastic recall, and then we ultimately get a VQ mismatch. Okay, so some areas are ventilated well, but not perfused properly, and vice versa. So over time, patients will develop chronic hypercapnia, and their kidneys will begin to compensate by retaining bicarb. Okay, but during an infection, such as here, this patient most likely has pneumonia, they can suddenly decompensate and the pH will fall. So we can see the answer options now, and it's important to note the difference between CPAP and BiPAP when you're answering this question. So CPAP, remember, is continuous positive airway pressure. It does not remove CO2. Okay, that's the important point. So this is most likely used for cardiogenic pulmonary edema, can also be used for obstructive sleep apnea and some cases of severe pneumonia. But for your exam questions, pulmonary edema and the cardiac cause and obstructive sleep apnea are the big ones. Then we have BiPAP. This provides positive airway pressure when you're breathing in and breathing out. So it actively assists ventilation and allows you to not only improve oxygenation, but also reduces CO2. Okay, so this could be handy in what we're trying to do with this patient here. So another important point to note is why it's a big exam trap and why patients will go into respiratory arrest. Okay, with COPD patients, we do not want to blast them with 15 litres or up to 15 litres of oxygen. Okay, and here's why. It's because, remember, in a normal person, breathing is driven mainly by carbon dioxide levels. Okay, so as CO2 rises, the brainstem increases the respiratory rate automatically for us to blow it off. In a chronic COPD patient, they live in a persistently high CO2 environment. So over time, the brain will become less sensitive to CO2. Instead, their breathing will become partially driven by low oxygen levels, otherwise called the hypoxic drive. So then their body is relying on low oxygen to keep them breathing. So then what happens if you suddenly give them a lot of oxygen? You'll remove that hypoxic drive, so the brain will no longer get the signal to breathe fast, and their respiratory rate will drop. The VQ mismatch as well will actually get worse, because remember, oxygen reverses hypoxic vasoconstriction. Okay, so you will get more blood and it will flow to poorly ventilated alveoli, which will make the CO2 rise even faster. And then you also get other effects in the blood. I don't know if people remember the Haldane effect. So this is when oxygenated hemoglobin releases CO2 into the blood, okay, because it will displace CO2 as oxygen binds more readily to hemoglobin. So the PaCO2 spikes rapidly as well. So this will kick it up even further. So the important point to note here is that we keep a target oxygen saturation in COPD patients who are CO2 retainers at around 88 to 92%. Okay, so then if we look at the answer options here, we can automatically rule out A, because this is premature. It's way too invasive to start with, so we're going to keep that in our back pocket, but we're not going to use it now. We will continue current oxygen therapy isn't correct, because this patient may be dead if we just continue to do nothing. They're clearly declining, and we clearly need to do something, so that's not correct. We just mentioned why we wouldn't administer 15 litres of oxygen. And then remember, between these two, CPAP isn't used in this scenario because we want to be able to blow off CO2. So our correct answer is a non-invasive ventilation or BiPAP. So really important question here. It's really important to be able to read an ABG. I've seen a lot of them come up on different AMC recalls, and also if you're doing AMC question banks and things like that, it also shows up a lot.